The U.S. is blocking all travel from the Democratic Republic of Congo, Uganda, and South Sudan right now, except for one soccer team that's about to land in Houston. The contradiction isn't a mistake. It's the exact shape of what happens when a public health emergency collides with a billion-dollar sporting event, and the machinery of government has to decide, in real time, which rule matters more. On May 17, the World Health Organization declared the Ebola outbreak in Central Africa a public health emergency of international concern. Within 24 hours, the U.S. Centers for Disease Control imposed entry restrictions on anyone who had been in the Democratic Republic of Congo, Uganda, or South Sudan in the previous 21 days. The State Department escalated its travel advisory to Level 4, do not travel for any reason. For most people from those countries, the U.S. border is now effectively closed. But the Democratic Republic of Congo's national soccer team is scheduled to play in the 2026 FIFA World Cup. Their base camp is in Houston. Their first match is weeks away. And on May 19, the U.S. government confirmed the team would be allowed to enter the country under a special exemption, while fans from Congo who want to watch them play remain blocked. The reason the outbreak triggered such a fast response is the virus itself. This isn't the Zaire strain of Ebola that the world spent years preparing for. It's Bundibugyo Ebola virus, a variant that has caused exactly 2 prior outbreaks, one in Uganda in 2007 that killed 37 people, and one in eastern Congo in 2012 that killed 29. There is no approved vaccine for it. There is no proven treatment. The medical infrastructure that exists for Ebola, the stockpiles, the protocols, the trained responders, was built for a different strain. This one is off the map. As of May 18th, the outbreak had generated 336 suspected cases in the Democratic Republic of Congo and 88 deaths, with 2 additional confirmed cases in Uganda, including 1 death. An American doctor working with a missionary organization in Congo's Ituri province tested positive and was evacuated to Germany along with 6 other Americans. His name is Dr. Peter Stafford. He was treating patients when he was exposed. The CDC is now monitoring everyone who came into contact with him. The speed of the U.S. response, travel ban in under 48 hours, reflects something officials aren't saying out loud. They don't know how fast this is spreading. The outbreak is centered in Ituri province, a region that has been destabilized by armed conflict for years. Health workers can't reach some areas. Contact tracing is incomplete. The WHO told the BBC the outbreak may be moving faster than the initial case counts suggest, but the fog of war makes it impossible to know for sure. Marco Rubio, the U.S. Secretary of State, criticized the WHO on May 19 for being a little late in identifying the outbreak. He didn't explain how the U.S. planned to do better while simultaneously cutting funding to the CDC and other public health agencies. The irony wasn't lost on anyone watching. Meanwhile, the DR Congo soccer team, 26 players, coaches, and staff, will be waived through U.S. Customs under an exception carved out specifically for them. The justification is that the team will undergo enhanced screening, daily health monitoring, and isolation protocols that ordinary travelers cannot access. The U.S. government is betting that a controlled environment, with medical oversight, is safe enough. What it isn't saying is whether that same controlled environment could be extended to, say, the hundreds of Congolese fans who wanted to fly to Houston to support their team for the first time in 52 years. The fans are still banned. The team gets to play. That's the mechanism. The exception is not based on risk, it's based on economic and diplomatic value. FIFA generates billions. A national team's participation in the World Cup carries political weight. A fan does not. So the border opens for one and stays shut for the other, even though both groups would be subject to the same 21-day incubation window and the same screening procedures. This is what selective enforcement looks like when the rules are written in real time. The CDC's restriction isn't technically a ban, it's a suspension of entry for non-US citizens who have recently been in the affected countries. That leaves room for waivers, exemptions, and case-by-case decisions. The DR Congo soccer team is the first, and probably not the last, example of how those decisions get made. The Bundibugyo strain has a case fatality rate between 30 and 50%. It spreads through direct contact with bodily fluids. It has no cure. And right now, it's circulating in a region where the international community has limited visibility and even less control. The U.S. response: close the border, criticize the WHO, carve out an exception for the World Cup, tells you everything about what gets prioritized when the next outbreak begins. It's not the science. It's not equity. It's whatever keeps the machine running.